So good morning or good afternoon. My name's Emily, and I'll be presenting today on cleft lip and palate. And so I'm a nurse practitioner, as Hayen mentioned, who works with the plastics team here at Seattle Children's. And my role is primarily on the inpatient side, so I see a lot of the post-surgical needs of these kids. But I also have a lot of colleagues who I work with and interact with who care more on the outpatient side and follow these kids through their lives. So today I'll be presenting throughout the lifespan the care of cleft lip and palate. And I just want to give a special shout out to Dr. Jay and Dr. Ann Hing, who are two of our craniofacial experts here. They provided a lot of the content for this presentation and resources, as well as excellent images of their patients. So just this disclaimer that you may be filmed or photographed during this presentation, so just be aware of that and keep your cameras off if you don't want to be filmed and photographed. And in terms of other disclosures, just a quick one that I have no conflicts of interest. I won't be discussing any off-label product use, and this class has no commercial support or sponsorship, and it is not co-sponsored. So our objectives for the next 50 minutes will be to provide a framework for genetic and prenatal counseling, management of feeding early in life, the pathophysiology of the cleft lip and palate, as well as the resulting functional issues associated with that. I'll also discuss screening needs for kids with cleft lip and palate, specific to hearing, speech, dental care, sleep, and psychosocial needs. And then lastly, I'll just review the resources that are typically included in a cleft program and some content specific to our cleft program here at Seattle Children's. So at Seattle Children's, we have a very comprehensive craniofacial center, and this center involves specialists of many different disciplines, everything from neurosurgery to just pediatric. We have craniofacial pediatricians who care for kids in more of a primary care perspective, and then we have psychologists, social work. We really have the whole gambit here, and that provides us the opportunity to really provide comprehensive care to our kids and follow them throughout their lifespan and support them as they grow and thrive. And our program's quite large. So typically we see over 900 patients with either cleft lip and or palate in a year, and about 160 of those are new. So we see a large portion of the population in the WAMI region within our program. And within 1 week, we'll see up to 3 new patients. And so it's a very common condition that we treat and one that our surgeons are experts at managing. So today we'll be exploring the journey of a child with cleft lip and palate throughout the lifespan. So starting in prenatal diagnosis all the way up to adolescence and eventually graduation. We'll see this timeline slide throughout the presentation. I think it provides a great image that you can follow along and see that really the care of kids with cleft lip and palate is not just in one moment, it's throughout their lives. So we're going to start at the beginning of life during early development of the fetus. So around 4 to 6 weeks of gestation, the face or components of the future face begin to develop. So you'll see the medial nasal processes and the lateral nasal processes that will eventually become nostrils, as well as the maxillary process, begin to form around this time. They're all really rudimentary, and so they haven't fully formed yet, but this is when development truly starts. You'll see the hole in the middle is known as the stomadeum, and it eventually becomes the mouth. So as this fetus begins to develop, everything kind of smooshes together and melts and eventually will fuse. So you see the medial and lateral nasal processes fuse together to create the rudimentary nostrils, and the maxillary process also fuses. So by about week 6, the medial nasal processes fuse completely with the maxillary processes to form the upper lip that you see here. And at the same time, the medial nasal processes come together to form the intermaxillary segment, which eventually will develop into the bridge of the nose, the philtrum, which is the dip in your upper lip, 4 upper incisors, and the middle of the maxillary bone, as well as the primary palate. And you'll see the primary palate here on the right. It grows from the back of the intermaxillary segments and grows until it reaches the incisive foramen, which is something that I'll show you more in a diagram form in the future. And we use the incisive foramen in particular, and why it's important is because we use it to determine severity of clefting. So by about 6 to 12 weeks, then the secondary palate will begin to develop. So initially there's 2 palatine shelves, and those eventually grow medially until they fuse together to form the secondary palate. And at that time, the frontonasal and intermaxillary segments will grow downward, and those create the nasal septum. This will fuse with the secondary palate, and this development of the nasal septum and secondary palate usually occur and complete by week 12 of gestation. So if there's any kind of disruption during this time period, those structures are at risk of being abnormal, and that's when we typically see the first signs of clefting. So orofacial clefting comes in many forms, and you can just see here, this is just a few of the varieties of clefting. It can be everything from an isolated cleft palate, isolated cleft lip, to a full cleft, bilateral cleft lip and palate. And we'll go into more detail in the future. So to talk more about different types of clefting, I'll be referencing this diagram, which is courtesy of Dr. David Fisher, who works with the Hospital for Sick Children in Toronto. And he has a really close relationship with Dr. J, who's one of our primary cleft surgeons here, and has provided this tool to understand clefting in more detail. So the primary components to note here will be the lip, the alveolus, which is the bony ridge under the lip where your teeth are rooted in. And then there's the hard palate and the soft palate that will also be involved in clefting. And finally, I just want to bring your attention to the velopharyngeal aperture at the back, and that has a key component in speech that we'll also explore. So when we talk about unilateral cleft lip and palate, there really is such a spectrum. So you can see in this image, there's everything from a micro cleft on the left, top left, all the way down to a full cleft on the bottom right. And we see a lot of variation. Each cleft is unique in its own right. This is an example of a unilateral incomplete cleft lip, and it's incomplete because it does not completely cleft the nose, it doesn't collide with the nose, and it doesn't involve the palate. So it's not cleft lip and palate, it's just a right unilateral cleft lip. And so you can see it just causes clefting solely in the lip and does not extend to the hard or soft palate. This is just the opposite. It's a left-sided unilateral incomplete cleft lip. And then when we see more complete clefting, it looks a little like this. So you see it hits all the way through hard and soft palate and causes significant premaxillary protrusion and widening of the cleft. There's nothing holding that lip together, the palate together, so it naturally opens wider with time. And for these kids, you'll note that this child on the bottom has a cleft uvula, and that's also something that we see, and we'll talk a bit more about in just an isolated cleft palate. In terms of bilateral cleft lip and palate, there's also quite a lot of variation. So we see everything from just a rather mild bilateral cleft on the top left, all the way down to full clefting with a lot of premaxillary protrusion on the bottom. When we look at just a cleft lip, bilateral cleft lip, we see something like this, the child in the middle. It doesn't involve the palate, but you see bilateral clefting. It can be a little bit more asymmetric than this, but typically does not impact the palate itself. Once we start talking more about clefting of the alveolus and of the hard palate, we see a lot more of that premaxillary protrusion I talked about, where the premaxilla is protruding more because there isn't much support on either side of the lip. And then when we see very cleft, bilateral cleft lip and palate, we see something like this child in the middle, where there is a lot of open space in the palate, and the premaxilla is very protruding. It's very difficult for these kids to feed, as you can imagine. Many of them end up with feeding tubes until their cleft lip repair, and it can be very challenging in the future in terms of future cleft deformities that need to be corrected. So sometimes kids will have an isolated cleft palate, and this can present in many different ways. So on the left here, you see just an isolated cleft palate, which if I saw that, it's pretty obvious, right? There's a cleft in the palate, and so that is just the basic of an isolated cleft palate. But there's variation too. So in the middle, you see There's a kid with a split uvula, and on the right you see a child with a submucous cleft palate. You can see there's a very faint, rather clear line in the middle of the right cleft, and that's really the primary clue for this child that they actually have an isolated cleft palate, besides the fact that their uvula has a slight cleft in it as well. So it can be very subtle and easy to miss, especially in newborn exams. Submucous cleft palate is interesting because, like I said, it's so easy to miss. It's often very subtle. There's that transparent area, it's called the zona pellucidum, where the muscle is abnormally connecting, and you can actually feel a bit of a ridge there, a bit of a gap in the muscle there, but it's hard to see if you're just looking. So it's really important that you feel the palate when doing newborn exams and other exams where you're concerned for clefting. And also, another just key to note is that the uvula is often cleft in these kids. And so if you see a bifid uvula or a cleft uvula, that can be just a normal variant. It can be just kind of a variant of normal. But for some kids, it's actually the key to identifying a submucous cleft palate. And while it looks rather mild, it does have enormous implications in terms of function and speech in the future. And so it's important to recognize this early and refer appropriately. So that was a lot of information, but just to overview, and we use a lot of nomenclature for cleft lip and or palate. So when we're describing something for just cleft lip and or palate, we say firstly, is it unilateral or bilateral? Almost all of kids with cleft lip and palate are just unilateral clefts, but it's important to make that differentiation. Secondly, we talk about incomplete versus complete. So that's referring to whether it reaches the nostril or not. So we classify it in that respect as well. But conversely, when we talk about isolated cleft palate, we usually describe it based on the palate involved. So is it a submucous cleft palate? Is it involving the hard and soft palates, hard or soft palates? There's a lot of variation, so we try to identify it in that respect. It's really interesting. They actually have very different demographic history. So for cleft lip and palate, we see it's far more prevalent in males compared to females, and it's a lot less compared to the isolated cleft palate, less associated with a syndrome. So only about 30% of kids with cleft lip and palate have an associated syndrome. Conversely, isolated cleft palate is more common in females compared to males, and almost 50% is associated with a syndrome. So it's really important to do a thorough physical exam. Outside of syndromic causes, there are many established causes and then possible causes that we think cause clefting. So established, meaning we've confirmed that there is an association between this and a clefting, orofacial clefting. Those things include things like a folate deficiency. Some anti-epileptic drugs can cause folate abnormalities, which can lead to clefting. Cigarette use during pregnancy and alcohol use during pregnancy are not good in many respects, but especially in clefting, it does increase the risk of orofacial clefting. And then there's constant research. This is an active area of research. And so some other associated causes are listed there. We think perhaps maternal diabetes and obesity might increase the risk, zinc deficiency, vitamin deficiencies of A, B6, and B12, as well as steroid use in pregnancy and cholesterol deficiency. So what do we tell families now based on what we know? Don't drink during pregnancy, that's step one, as well as don't smoke. We also tell them only to take approved medications that are approved by their obstetrician, and to eat healthy to the best of their ability. Taking prenatal vitamins continues to be really important, and we advocate for that. And then we also provide empiric counseling to families who do have strong cleft history, providing them the information they need to plan ahead and know the risk of their child having a cleft. And genetic syndromes are really important to note when we're talking about a new cleft diagnosis. They can sometimes give us some insight into the underlying cause of the cleft. They can also guide our screening recommendations and treatment options for these kids, especially if we know that a certain syndrome is associated with certain risk. And it also provides us an idea of the prognosis of the child and recurrent risk for future pregnancies. And some examples of common syndromes and their associated risks are listed here. Some of the most common that we see are things like van der Wood syndrome and Pierre-Robin syndrome, which I'll go into in a little bit. But any syndrome really gives us some insight into many things: surgical complications, any associated birth defects that might not be obvious visually, and then also risk for developmental delays, so we can really get in early and start early education and early access to resources for these children. It also gives us prognosis, an idea of prognosis for long-term outcomes. So we're going to return to this timeline of cleft care now. So now that we've established fetal development of clefting and their etiology and nomenclature, we're going to move forward into the diagnosis and prenatal counseling. So if a child is identified prenatally to have an orofacial cleft, the first step will be prenatal counseling. And really, the benefits of prenatal counseling are obviously that we provide anticipatory guidance to families. We give them an idea of what to expect, of what their child's life will look like. But then the difficulty lies in that we don't really know the extent of the clefting a lot of the time. Ultrasound is great, but it's not especially great in defining cleft severity and palate involvement. So, it gives us an opportunity to connect early with these families, but is limited in its use. During those visits, we involve several team members. We usually involve a craniofacial pediatrician who will overview the health of a child with cleft lip and palate, as well as explore family history and risk in a family, as well as the ultrasound findings and an overview of the management of the cleft. Nursing is involved in counseling for feeding and nutrition, and that's a really important thing for these kids to grow and thrive. So they provide information about bottles and special bottles and tools that we can access for the families after birth to support their nutrition and growth. And then lastly, social work is a special part of the team, and they are great in that they connect with the family, identify any resources that they might need, and also clarify expectations for the family in terms of financial and medical needs of their child in the future, and support them as best as we can. So prenatal diagnosis is becoming increasingly more common, but still has a really wide range of accuracy. The literature currently says about 16 to 93% are identified prenatally. Such a wide range because, it depends on many things. It depends on the cleft type and severity. It really depends on the fetal position. If the baby is hiding, you're probably not going to get the best view. Maternal body habitus, and then also the expertise of the sonographer is a key one. So having a children's hospital here is great, and that our sonographers are very experienced in diagnosing stuff like this, but more rural places may not have as experienced sonographers, which impacts the accuracy of diagnosis. So going back to this timeline, we're going to move on to birth. So baby is born. So during the initial assessment, the clinician must establish the extent of the clefting. And like I mentioned, you have to look, you have to feel. It's really a detailed process, although some clefts are very apparent from just looking at the kid. During the initial assessment, it's really important that you also note associated anomalies, because those are clues as to whether perhaps this child has a syndrome. So you see here on the left, top left, there is a child with micrognathia, which is when the jaw is small and misshaped. It's malformed and a little pushed back because it's so small. And that is associated with Pierre-Robin syndrome, which is also a cleft syndrome. At the bottom, you see cleft lip pits. You see those little pits on the lip. That's associated with van der Wood syndrome. And then there's several other things. Cutis aplasia is in the middle top, as well as polydactyly, so an extra toe. And then on the right or left, the hand, it shows an extra palm or crease. And all of those are red flags for us as providers that maybe this child has a syndrome that should be screened and brought to light. For Robin sequence, I just wanted to highlight it because it is something that we see quite a bit. The key components of Robin sequence are micrognathia, so the jaw is underdeveloped, glossoptosis, where the tongue is downward and backwardly displaced, And that often can contribute to airway obstruction. So you see on the right top, the airway is quite narrow, and that's a combination of both the micrognathia and glossoptosis, as well as just other abnormal anatomy that impacts airway a lot. And then at the bottom, you see typically these kids actually have an isolated cleft palate that's U-shaped. It's pretty distinctive. So when we look at this baby and we talk about feeding, normal feeding is based on seal. So the palate will move back and upwards to create a seal, and then the posterior and lateral pharyngeal walls move to contact the soft palate to create that negative pressure that allows a baby to suck in their formula, breast milk, whatever they're eating. The jaw and tongue will also drop down to increase the size of the oral cavity, which further generates negative suction. But as you can imagine, when a kid has a cleft lip or a cleft palate or both, it is enormously challenging to generate suction and to feed. So what we see with kids with cleft lip in particular is that often they have difficulty getting a good lip seal. If there's a hole, it's hard to seal that up. So obviously that's difficult for them. Along with that, because there's no seal, they deal with a lot of leakage around the lips. So difficulty getting the formula that you think you're giving them because it's coming out from the lip or nose. They also have issues with swallowing air. For cleft palate, we see a lot of issues with nasal regurgitation and failure to produce negative pressure because there's a hole in the palate. And this leads to prolonged feeding and fatigue, which can be really challenging and need fortification of formula. There are some bottles that we usually recommend for kids with cleft lip and palate that are helpful in delivering formula. So the Haberman and the Dr. Brown's are the two that I'd say we use the most. They both work similarly. They have a one-way valve that leads to the nipple, and jaw compressions alone actually deliver the milk. And I'd say the Dr. Brown is far more common and is even being used for kids with reflux these days, so it's pretty popular. Alternatively, there's the Pigeon and the Mead Johnson, and those work in their own special ways. The Pigeon is a one-way valve into a nipple, but it is a really big nipple, and so it's really difficult for newborns to use. Conversely, Mead Johnson is, I haven't really used this in my practice, but it's supposed to help with coordinating the squeeze with suck, swallow, breathe. So it's used mainly in newborns and young babies. So going back to our timeline here, now that we have checked out this baby and we've established they can feed, we are going to move our attention to surgical considerations, where our goal is to produce a normal form and function, and we need to consider growth and development within that. So I'm going to break it down within the first year of life for a baby. So we'll go from initial assessment to the first year, cleft palate repair. So after we've established this child has a cleft, we offer presurgical molding. And these are external forces that can be used to mold the lip to bring it closer together in preparation for eventual surgical intervention. So there's everything as rudimentary as lip taping to nasoalveolar molding, where they use kind of a retainer-like device to mold the lip closer together. But as you can imagine, those are very tough to keep your baby in. It's hard to see your baby wearing something like that so young, and can be challenging for follow-up as well. Presurgical molding is helpful for some kids and not so helpful for others. So the wider the cleft, generally the greater the benefit, but for kids who have clefts that are relatively approximated, there's not really the point, and it's a lot of hassle for the family. So all of this needs to be considered within the family context. Their geography, because it requires repeat visits to us. It might be tough for that kid who's from across the pass. The baby itself, is their cleft wide or narrow? The family situation, is this a family that's going to reach out when there's issues, that's going to follow up, that's going to be okay with coming in so frequently for checkups? And then just the medical condition of the baby in general. So going on, next we're going to move to 3 to 6 months when we really worry about speech, sleep, hearing, and development. And as part of that, we really focus that time period on the cleft lip repair, which is so important for babies to begin to use for speech as well as developmental goals. So we usually do cleft lip repair between 3 to 6 months, and the reason we do that is that we found that the risk is relatively low for anesthetic risk. Growth is typically sufficient, and there's actually really robust anatomy by that time frame. And the repaired lip will mold to the palate, which is nice for future palate repair. So our plastic surgeons spend a lot of time planning these incisions so that things fit together so nicely, and it's kind of like a puzzle. Really, the goal of the cleft lip repair is to reconstruct the muscular sling around the mouth. So this muscle needs to be released from its abnormal insertion, which you see kind of near the nose, and then reconstructed to a functional manner to support the mouth. And this sequence really shows the difference in the insertion of that muscle. You can see it's inserted near the nose, and so with movement, the cleft widens even more and more. And so the purpose of this cleft lip repair is really to reconstruct the mouth and that muscle. So in order to correct the resting nasal deformity of a cleft lip, we really must correct the external rotation of that the lip, as well as the nasolabial fistula, the hole there that you see at the base of the nostril. So we rotate the tissue in to connect and secure the nose, the nasal bridge. And so I'll go kind of through a case study next. So this is a baby who has a pretty wide, she used to have a pretty wide cleft. She actually went through nasoalveolar molding, which is why her cleft is relatively small in this imaging. And after nasoalveolar molding, you can see there's a lot more approximation of the nostril and of the upper lip. So for her repair, she it set her up for surgery by using the nasoalveolar molding. So you can see everything's nicely approximated. And our surgeons were able to do a beautiful job in connecting both sides to create a really aesthetically pleasing nostril and lip for this baby. So 1 week post-op, you can see the change is immediate and pretty awesome. The nostril on the right is a little abnormal compared to the left, but is enormously more round and is more supported. And then the lip repair you see is beautiful. It's well approximated, healing nicely, no concerns there. So after cleft lip repair, we often will send babies home with nasal conformers or stents in their nose. Those are sutured in, and their purpose is to further mold the nostrils. They're typically only used for about a week, so we'll have that baby come back in a week for the stent removal. And during the week that they're at home and working on feeding and just healing after surgery, these families will need to use saline spray to keep those stents nice and open. We also recommend no pacifiers in that week after, just because we don't want anything to damage the cleft lip repair. And then they should keep the incision clean and dry with a thin coat of Vaseline to encourage moist wound healing. So we typically see these kids at 1 week out for stent removal, and then we'll have them see the surgeon further down the road. So this is at a 4-month post-op to ensure that everything is healing as expected. And you can see the difference is just remarkable for this baby. She went from such a pretty significant cleft to a beautiful repair with a nice intact lip and a beautiful nostril. So going back to our timeline, we're going to move on next to cleft palate, and that is typically done around 12 months of age. So the reason we do it closer to 12 months is, on one hand, early surgery really risks greater facial growth disturbance, and then late surgery might impact development more significantly. So we found just the sweet spot seems to be 1 year of age, and so that's when we typically do the palate repair. So I'm going to flip this diagram upside down so we can show you the view of a surgeon. So first, we close the cleft in the palate by repairing the nasal mucoperiosteum across it. So you can see that there. And then we close the oral mucoperiosteum by using lateral relaxing sutures or incisions, and that just brings everything to midline. It recruits the tissues to midline and leaves lateral defects. So you see those little gaps on the side, and those are left to heal on their own through secondary intention. So we do not close those. Post-op, these kids are typically admitted overnight for observation, just to make sure they can eat and their pain is controlled. And then they usually discharge home. They're on a soft, no-chew diet for 6 weeks, and they need to avoid crunchy foods to avoid any kind of damage to the repaired palate. And those sutures are actually all absorbable, so that's pretty nice. Sometimes we'll get calls from families, oh, my child swallowed a suture, and they are absorbable, so no need to panic. These kids, because we don't want anything in the mouth disturbing the repair, they need to wear mittens or no-nos, which are those little straitjacket arm wraps, just to prevent them from putting their hands in their mouth. And we also recommend no pacifiers, sippy cups, hard toys or forks or straws, things that could damage the palate repair during that post-op period. And then the follow-up typically is about 3 to 4 weeks after surgery in clinic with the surgeon to just make sure everything is healing as expected and the outcome is as expected as well. So next we're going to move on to toddlers and preschool age, where again, the goal is really focused on enhancing speech, making sure sleep is not an issue, and focusing on hearing and development. And speech is such a complex function, and it requires this feedback loop of many, many components. It's influenced by cognitive, auditory, and articulatory function, all to create speech. In terms of articulatory function, and we focus a lot on the velopharyngeal sphincter, and that's this kind of soft velum at the back of the throat that is involved in speech. So when we talk, the velum blocks airflow from the nose during normal communication unless you're making the M sound. That's kind of the exception. So here you see the velopharyngeal aperture is open, but it moves back and down when you go to speak. And airflow can come up and out. So for M, there's air movement through the nose, and that's abnormal. So when we talk with other syllables, for example, ba, 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 the velopharyngeal aperture closes and the airflow will go up and out through the mouth to create the ba sound. So is one of the only consonants that involves airflow through the nose. But for kids with velopharyngeal insufficiency, the velum doesn't properly block the back of the throat, and this leads to nasal communication and hypernasality. So their speech is very, very nasal and impacts intelligibility for these kids. It's really common in kids with cleft lip and palate, with an estimated 25% of kids experiencing VPI. And so it impacts their speech and also can lead to compensatory misarticulations or articulation errors, things like glottal stops, puffs, squeaks, snorts, all because they're unable to generate pressure in the mouth because of the hypernasality. So there's a lot of variability and difference in severity of VPI, but it does have pretty significant implications for these kids in interacting with their peers and adults because it impacts their intelligibility so much. So to kind of combat that, we have speech-language pathologists on our team, and their role is multifold. So they help diagnose the etiology, they determine articulatory problems and compensations, and then they use those to guide their speech training for children. And VPI is difficult in that if speech training doesn't work, sometimes we try what's something called an obturator that is essentially like a retainer that blocks airflow. But we can also need surgery to surgically fix VPI. 10 to 15% of kids with clefts will need surgery, and there's multiple different types here that are performed, and our otolaryngology colleagues do this as well. Furlough is the most common, but there's some variation. The risks of surgery versus the benefits is kind of tough. So the benefit is obvious. It improves speech quality and decreases those compensatory functions that might also damage vocal cords. But then the risk is that perhaps it's too effective and it actually leads to obstructive sleep apnea. And unfortunately, sleep disordered breathing is already an issue in kids with cleft, even those who don't have surgery for their VPI. So about 20 to 34% of kids with cleft will have sleep disordered breathing, and that's 3 times what other children who don't have craniofacial abnormalities might experience. So treatment options for sleep disordered breathing are multifold, but tonsillectomy and adenoidectomy is typically a first step. Sometimes these kids will need CPAP for positive pressure support. They also sometimes will go through a repeat surgery where they revise the repair if it is related to the surgical repair of their BPI. And then lastly, we also offer mid-phase advancement, which we'll go into in a little bit more detail in the adolescent phase. If the child has mid-phase hypoplasia, meaning the mid-phase is pushed back, that's impacting their sleep. So you can see here in this x-ray, the middle image shows mid-phase hypoplasia. So the maxilla and the mid-phase are pushed back, but after surgery, it's brought forward, which has really expanded the airway for this child. So going back to this loop, next up we will be going into hearing. And hearing is so important for all kids, but especially for cleft populations. They often deal with eustachian tube dysfunction. It's very, very common. And so we do pretty aggressive hearing screening for kids with clefts. Starting at birth all the way through toddler and preschool years, we do annual audiograms. If they have a cleft palate, and really are pretty aggressive in our involvement with audiology, and they're great resources for us. We use ear tubes as well to help with hearing. So typically ear tubes are placed during the initial cleft palate repair at about 1 year of age, which works out nicely as these kids head into their toddler years full of daycare and ear infections and other infections. So we place the ear tubes around 1 year, and then we'll continue those as needed. So often they'll place T-tubes, which are a little bit more longer term than the classic bobbin ear tubes. And those provide the opportunity to treat directly to the source if there are infections versus offering systemic antibiotics that might lead to more resistance. And returning to the feedback loop, we're going to next discuss speech signals in the context of psychosocial interaction. So these kids often deal with a lot of challenges. Firstly, their deformity is on their face, which is tough. In our culture, the face is the center of interaction and social cues. And so to have an abnormality of the face is just really tough, and especially for kids who can be rather cruel about facial differences. Secondly, they often have issues with intelligibility and how they're understood, sometimes due to BPI or palate differences. And so that can be just so challenging when you're trying to connect with a peer and they don't understand. And so all of these things often will lead to issues with interpersonal relationships within the family, with others, might lead to behavioral problems, and often leads to bullying, unfortunately. And so for that, we do have psychologists on our staff who provide great counseling for these kids and try to normalize things. We work on, obviously improving function in other ways, surgical if we can, and speech therapy. And then we also provide some access to community resources like Camp Corey, which is a fantastic camp. It's a summer camp for kids with lots of disabilities, but they have a week for kids with craniofacial differences where kids can connect with others who have their shared experience and just feel normal. During this time, we also begin to see dental caries, and these are far more prevalent in kids with cleft lip and palate. The causes that we think are contributing to the increase in prevalence are things like bottle drinking. So we mentioned the special bottles, and those kids will sometimes continue to use those, and that can lead to increase in caries. Also, there's some literature that supports that kids have a reluctance to brush on their clefted side, which might impact to some buildup in dental decay. And then also issues with poorly aligned maxillary dentition, limited access after surgery. So if your mouth is so swollen, you're not going to want to brush, and you likely won't brush. And then lastly, scarring. So while surgery, we try to prevent any excessive scarring. Sometimes there can be contractures or scars that limit opening of mouth, and all of those things combined mean that these kids have a higher risk of dental caries and are monitored really closely with dentistry. So moving on, now that we've discussed toddlers and preschoolers, we're going to talk about kids during the school age period. During the school age period, we focus a lot on the alveolar ridge, which you see here. It's the bony ridge under the teeth that kind of cements teeth and lets them grow out. So for kids with cleft lip and palate, they often will have an alveolar cleft, which you see here, where teeth are unable to grow. So we do, for that, we do an alveolar bone graft. And the timing for this, as all of these surgeries, is a little complex. If we go too early, it risks growth disturbance. But if we go too late, then it risks dental loss. And so we have found that during a period of mixed dentition is best to maximize growth and support permanent tooth growth. Typically, that's around age 8 or 9. So when we're planning, we need to examine the alveolar ridge cleft. So as you can see here, it's the bony ridge that provides stability for teeth. And to fill that space, we actually use a bone graft from the iliac crest, as you can see here. So they'll take the cancellous bone, which is that spongy interior bone from the iliac crest, and transplant that into the cleft. We use cancellous bone because it's extremely vascular and has the best results in terms of grafting. So you can see here the bone is placed in the cleft and then secured with dissolvable sutures. And they also close the hip graft site with just steri strips. And once it heals, it's pretty remarkable. So now that the graft is fully healed, the child should have a newly intact alveolar ridge, and permanent teeth can erupt from that and take hold. So postoperatively for these kids, we typically recommend a pretty cautious diet. We really don't want anything to impact this beautiful graft. It's pretty tenuous at times, and so we recommend a full liquid diet for 24 hours and then proceeding to a soft no-chew diet for about 6 weeks. They also do really extensive oral care. So we do warm saltwater rinses after meals. We use a special rinse called chlorhexidine that is used for 2 weeks post-op. And then we also recommend diligent dental hygiene to make sure that the graft doesn't become infected, because that is one of the primary reasons for graft failure. Typically, the graft is evaluated at about 4 weeks after surgery by the surgeon, and then we see them back in dentistry about 4 to 6 months later, and that's when they do imaging to see if the ABG has worked. So you can see here before there was a rather sizable cleft, and after the alveolar bone graft, there's a great improvement in that cleft, and it's filled in with a new bone. So moving on, next we're going to focus on adolescence when we talk more about septorhinoplasties and graduation. During the teenage years, that's when the jaw has mostly matured, and so we can focus more on jaw repositioning surgeries. So a lot of kids with cleft lip and palate will have maxillary growth deficiency, so their maxilla isn't growing as expected, and that can lead to poor occlusion. So you can see here her midface is quite hypoplastic, and she does not have an appropriate occlusion with her teeth. So typically the first step for these kids is orthodontic treatment with braces, but if that doesn't work and it's still moderate to severe, we do offer jaw surgeries. So we do both top and bottom jaw surgeries. So for example, for a teen with a skeletal underbite, the standard is a Lafort 1 osteotomy, which advances the top. But if they also have components of mandible abnormalities, then we also offer lower jaw surgery. So sometimes we'll do those in combination. After the surgery, they're typically in elastics to hold tension to the new jaw and prevent it from going back to where it used to be. Sometimes we'll use distraction devices as well. Moving on, next we're going to talk about the septorhinoplasty. And during the initial cleft lip repair, they do a lot of manipulation of the nose. It's considered like a cleft rhinoplasty in of its own right. But in teenage years, we offer a second septorhinoplasty, and this is primarily to straighten the nose and correct airway obstruction. So a lot of these kids, you can see the nostrils don't have a lot of support in the nostril sides, and so it will collapse really easily. They also often have septal deviation that impacts their airflow, and just to boot, it's asymmetrical, and so some kids will deal with a lot of bullying related to their nasal deformity. So we offer a septorhinoplasty to combat that. And the As you can see, there's a lot of deviation and asymmetry of the nostrils here. And so our goal is really to create a more functional airway and aesthetically pleasing nose. You can see post-op, there's a far more symmetrical nose. Of course, it's not perfect. It's hard to be perfect, but it has a lot more openness, and it has a corrected septal. It's no longer deviated. The septum is straight. So in order to create a more open nostril, you see here it's rather collapsed on the left side. We use actually rib grafts or ear cartilage to bolster that nostril to create a more secure opening, and also to support the columella. So you see in this first picture, the columella, which is the underside of your nose, is collapsed. It doesn't have much support. So we use grafts to support that area, and that improves function. So post-op, these kids will typically stay, they'll go home the same day. Some of them are admitted for pain control if they have a pain history, but typically it's a same day surgery. They usually will have nasal stents in place to assist with the nostril formation. And then they also have it's called a mustache dressing, but it's just a huge piece of gauze we put over their lip, and that just helps to catch any bloody drainage. We use Afrin for 3 days post-op to help decrease bleeding, and also nasal spray to keep everything moist and encourage wound healing. Ibuprofen, Tylenol, Oxy, the standard for pain control, is usually used. And they return about 1 to 2 weeks post-op for stent removal, and they also have something called an aquaplast, which is on the top of the nose, and we'll remove that too at about 2 weeks post-op. In terms of precautions for these kids, no swimming for about 6 weeks, which is our standard, no heavy lifting or strenuous activity for 6 weeks, all that to prevent trauma to the area and the new repair. So we are nearing the end. So next and last is graduation and counseling. So in terms of graduation, when a child graduates from our program, they typically undergo cleft-specific counseling with either a geneticist or usually their craniofacial pediatrician. So because the cleft lip and palate can be really closely linked to genetics, we think it's really important to have our genetic counselors discuss the prevalence of this in family and the likelihood of future family to experience orofacial clefting. So this empowers kids to really be informed as they head into the world and assist patients with that transition. We also help facilitate transition to adult care. We have a transition program here at Seattle Children's that we use, and then also just connecting with our colleagues at the U to establish ongoing care for the cleft. So as you can see, there's many parties involved in the care of these kids, and it's a complex process that involves screening, treatment, surgical interventions, and many more components of care. And so it's requires a huge team to do so, and I'm so honored that I work with some of the leaders in our field. Our surgeons are just fabulous and have published a lot on advancements in cleft care, and the rest of our team has always just been so supportive of our kids and each other. And I think together we provide a really comprehensive cleft program that serves our community well. And here are some of the beautiful faces I work with. Whew, so that's it. Any questions?
Thank you so much. The visuals are always so helpful for this topic. If you have any questions for Emily, please put them in the chat and I can ask on your behalf. I do have a couple of questions to get us started off with. Emily, can you speak about kids who are thumb suckers and with also cleft lip and palate, and how does that impact their repairs if they are thumb suckers?
Yeah, thumb suckers are tricky. So during cleft lip, we worry less about the palate because we didn't repair the palate, it's the lip itself. And so we actually don't require like mittens or no-nos to protect them from damage to that area. But for the palate, we really need to protect that pretty aggressively. And so we will provide families with mittens and then also no-nos to keep the arms straight. And unfortunately, the baby's just going to be really unhappy for a while during that 6 weeks post-op while they're healing because we cannot allow hands in the mouth during palate, after palate repair.
And does that, let's say you are able to keep them immobile so they don't suck on their thumbs, but once that's healed and the thumb sucking continues, I hear that it can last for a while for the thumb sucking. Does that impact their palate development at all, or any repairs or anything like that in the future?
It might increase the risk of an oral nasal fistula or a fistula in the palate. And that's a great question, and one that I personally haven't seen like a return to a palatoplasty because of thumb sucking. But certainly I'd imagine it would impact the healing long term, might create a little divot in the palate repair and increase the risk of it opening up again. But the hope is that by 6 weeks, it would be mostly healed and strong enough to withhold just gentle pressure.
Okay. There is a question from a participant. Are there any kind of socioeconomic barriers to getting the repairs done in the ideal timeline of within the first year of life?
Yeah, there's a lot of social components to this. It requires a lot of repeat visits to us. And so for kids who come from more rural areas or parents who have uncertain transportation access, that can be challenging. So we do have a social worker on our team who works really hard to connect families with resources so that they can access care. But it certainly is something that we see a lot, where families might no-show for their pre-op visit or cancel because they don't feel like they're in a place financially to proceed with surgery. You also have to take away time from work if you're a parent, which can be challenging for kids from certain socioeconomic backgrounds. And so that's a barrier that we always recognize and try to preempt by involving social work pretty early and guest services, but does impact access to care and sometimes delays access to surgery for some people. And so it's something that we try to keep in mind pretty closely. And then in terms of economic needs, luckily at Seattle Children's, we have the Uncompensated Care Fund. And so for families that qualify, we can offer that to supplement or cover any surgical needs for their child.
Thank you for that. You mentioned that it's becoming more common, or you're seeing more patient cases for cleft lip and or palate. And looking at your volumes for your area, it's pretty big. Are you seeing that the increase in patient numbers, does that correspond with population growth, or is it more so because it's just becoming more common because of environmental factors, or what would the explanation be for increasing rates of patients with cleft lip or palate?
I'm not sure if I misspoke. I don't think I said that the rates were increasing, but we do see a large volume. Yeah, they haven't necessarily been increasing objectively, but we do see a large volume, and as WWAMI outreach has expanded, we do see a lot more kids from places like Alaska, Idaho, Montana who need cleft care.
Mm-hmm. Oh, okay, got it. I think just maybe from your slide, I might have misunderstood the diagnostic rate. I mean, it was a pretty wide range anyway for the prenatal diagnostics.
Yeah.
And then there's another question: does the maternal diet or nutrition status impact the risk of cleft lip palate?
So some studies have suggested that maternal obesity or vitamin deficiencies increase the risk of clefting. So yes, it is something that's being actively explored, and there's concern that maternal obesity and then deficiencies in, I believe it's vitamin B6 and 12 and A, might lead to clefting.
Okay. Thank you. Any other questions for Emily? Just a comment. Thank you for an excellent presentation, great visuals and treatment process. And there are a lot of different specialties involved in this, in the care of this patient. I had no idea the follow-up and the follow-through for this patient, and it seems it's almost like a lifelong follow-up process. So thank you for sharing your work with us.
Of course, I'm so glad I was able to speak with you all today.
Yeah. All right, everyone, have a good rest of your week, and Happy New Year. Thank you, Emily.
Thank you all.